Welcome to the Practicing Clinicians Exchange podcast on ASCO GU conference coverage. This podcast will highlight late-breaking and important new and promising data in the management of castration-resistant prostate cancer. I am Brenda Martone, a nurse practitioner with Northwestern Medicine in Chicago, Illinois, and I will be your moderator for today's episode. Joining us today is Dr. Alicia Morgans, genitourinary medical oncologist and medical director of the survivorship program at the Dana-Farber Cancer Institute in Boston, Massachusetts. This program is supported by an educational grant from Janssen Biotech, Inc. This program is provided by Practicing Clinicians Exchange for 0.50 ANCC and AAPA credits, with 0.5 credits applicable for pharmacology credits for NPs. To receive credit for this program, go to pce.is/ASCOGU. So that's pce.is/ASCOGU. The learning objectives for today's podcast are to identify recent practice-changing data in castration-resistant prostate cancer, and to describe strategies for management and monitoring of patients with castration-resistant prostate cancer based on the most current efficacy and safety evidence. So we have 5 selected trials that we are going to present to you. And I'm going to throw out the first question to Dr. Morgans regarding 2 phase 3 studies presented at ASCO GU, both Propel and Magnitude, evaluated the addition of a PARP inhibitor to abiraterone in the first-line setting for patients with metastatic CRPC. Can you tell us about these studies and highlight some key differences in their design?
Sure, and thank you so much, Brenda. I'm really excited to talk about these studies because it was an extremely exciting GU ASCO 2022. And part of the reason was because we had 2 studies that were looking at combination therapies for patients who were getting treatment for first-line metastatic castration-resistant prostate cancer, or mCRPC. I'm going to talk through each of their study designs, then we'll highlight the differences, just as you said. So the first is the Propel trial. And in this study, patients had a history of new untreated mCRPC after progressing on ADT alone or ADT and docetaxel for metastatic hormone-sensitive disease. They couldn't have had prior abiraterone, and they were really an unselected population in terms of DNA repair defect alterations. All patients were enrolled and underwent randomization to abiraterone with or without olaparib. And remember, this was an unselected population. So that was really, I think, an interesting twist that was based on some prior data from an earlier phase 2 study that suggested that abiraterone and olaparib may be beneficial even in patients who didn't have underlying DNA repair defect alterations. These patients were followed for a primary endpoint of radiographic progression by the investigator's assessment. And then, of course, key secondary endpoints for this phase 3 trial include overall survival, health-related quality of life, safety, and other important and relevant disease control type endpoints. The other study was the Magnitude study, which is also looking at this first-line metastatic CRPC setting. Again, patients had progression of their disease on ADT alone, but they could have also received 6 cycles of docetaxel in that metastatic hormone-sensitive setting. They could not have had prior exposure to abiraterone. But importantly, these patients underwent testing for DNA repair defect alteration status prior to enrollment in the trial or during that screening process. Patients were enrolled in both a biomarker positive and biomarker negative subset. In both sets, these patients were treated with abiraterone with or without niraparib. So it's very, very similar, but there are these 2 cohorts, biomarker selected positive and biomarker negative. Importantly, in the biomarker negative population, there was a futility endpoint that was built in to assess whether or not this population was actually going to benefit from the combination of niraparib and abiraterone versus abiraterone alone. And after the first couple hundred patients, they actually identified that there was no clear substantial benefit of the combination of niraparib plus abiraterone versus abiraterone alone. And so the biomarker negative cohort was closed to further enrollment. However, the biomarker positive cohort continued enrolling, completed enrollment, and was followed for a radiographic progression-free survival endpoint, this time by central review, and included secondary endpoints that were quite similar to the first, including overall survival, health-related quality of life, and other endpoints. So clearly, these studies are both looking at combinations of abiraterone and a PARP inhibitor, using these two different PARP inhibitors, but they had slightly different designs in that one study included all comers and didn't have DNA repair defect testing in the upfront setting. And that, of course, is the PROPEL trial. Whereas the other study had upfront DNA repair defect testing and enrolled patients in cohorts based on their DNA repair defect alteration status, and then ultimately closed the HRR DNA repair defect mutation negative cohort. That was the magnitude study.
So in terms of these studies and PARP inhibitors, and if they gain approval in this first line setting, how do we select which PARP inhibitor for which patient?
Sure. With both of these trials, what we found was that radiographic progression-free survival was improved with the combination of abiraterone plus the PARP inhibitor. In the PROPEL trial, this was abiraterone plus olaparib, and we saw this improvement in our PFS. And in this setting, of course, remember, this was an all-comers population. So what we found here was that the hazard ratio was 0.66. This was a highly statistically significant benefit. And again, all-comers population. Whereas in the magnitude trial, this is again looking at niraparib in this setting. This is really just the DNA repair defect or HRR mutation positive cohort. And here we found a hazard ratio of 0.73. And this was a highly statistically significant benefit as well, with a p-value of 0.0217. So neither of these PARP inhibitors are really approved in combination, so their label does not cover that. And niraparib is not yet approved for use in prostate cancer, though I assume that that will be something that's in process over time. So this is not necessarily something that we would act on at this point in time. And I would say that's also important because this is a radiographic progression-free survival endpoint, not an overall survival endpoint. However, we do know that olaparib is actually approved in the metastatic CRPC setting. And this is for patients who have specific DNA repair defect alterations, some of the most common being BRCA2. BRCA1 is also one of those alterations, ATM, PALB2, CHEK2. So there are a number of these. And olaparib is approved in this setting either before or after chemotherapy, but it is in the mCRPC setting. So we can use olaparib in an HRR selected population right now in the mCRPC setting, but we can't necessarily apply the data from these two studies in our clinical practice quite yet, given the label has not yet been expanded. And at this point, we still only have a radiographic progression-free survival data on this. So Brenda, when you hear this information, of course, and I know you've used these agents, what are you thinking about in terms of the side effects that you're going to have to manage for these patients? And what do you think about in terms of monitoring, especially if we end up using these agents in combination with abiraterone?
Thanks, Alicia. That's a really good question. In terms of PARP inhibitors, the class effects, they actually have certain side effect profiles. For us in oncology with PARP inhibitors is we need to monitor for blood counts. So CBCs to watch for hemoglobin falling, platelets, and white blood cells. We also need to monitor liver function and make sure patients are tolerating the medication. There is sometimes nausea with a PARP inhibitor. So sometimes we have to use an antiemetic before dosing. Patients need to be seen more frequently on a PARP inhibitor with or without abiraterone, of course, to monitor for these side effects. So there's more frequent follow-up with labs and visits. The combo PARP inhibitor with abiraterone, we do know that the combo is tolerated in the metastatic CRPC setting. Abiraterone is a second generation AR inhibitor. And so the most common side effects that we see with this is there could be some fatigue. Again, we need to monitor for liver function abnormalities. And obviously with a combo, you have to watch that liver function more closely. There's not so much nausea or vomiting with abiraterone, which is good. There can and cannot be some diarrhea. In terms of fatigue, again, it's minimal. Again, just lab work, monitoring for side effects, keeping a close eye on electrolytes with the abiraterone, like the phos and the magnesium, as well as, sodium and potassium. And then again, the question that always has to be asked is with the abiraterone, how are you taking it? So depending on the formulation of 500 or 250 milligram tablets, asking them how they're taking it, make sure they're taking it once a day and not 4 tablets 4 times a day. And the follow-up question is, are you taking your prednisone with food and making sure that they're not missing any doses, because that prednisone serves a very important role in helping mitigate some of these electrolyte changes.
That's great. And thank you so much for that. What I think about too, whenever starting patients on these medications, is making sure that I think about their comorbid illnesses and whether they have a history of cardiovascular disease. Certainly monitoring blood pressure and fluid retention in the setting of abiraterone is always important. But generally, I think it's really encouraging that for both of these trials, we did not see really synergistic adverse event profiles, meaning these drugs didn't seem to build on each other and make worse side effects when combined. They pretty much seem to show the side effects that we would expect with each of these agents if used individually. And I think that's encouraging as we think about use of them in our patients, because we really have a fair amount of experience with all of the agents that we've talked about. For the most part, we'll continue to get experience as we use these agents more frequently in men with prostate cancer. Generally, these side effects are things that we can handle pretty routinely in our cancer clinics, which is always a good thing.
I agree. I'm really glad you brought up the multidisciplinary approach. We always need to involve all providers involved in patient care, especially when starting new regimens. So it's very important that there's good communication in case medical management or medicines doses need to be changed. So thanks so much. I think we should move on to the enzalutamide in the PRESIDE trial. That trial was looking at enzalutamide or continuing enzalutamide and adding docetaxel after progression on enzalutamide. So tell us a little bit about that trial. And also, do you think this trial is practice changing?
Sure. I think that this was really an interesting trial, and of course was one of the oral abstracts presented at GU ASCO 2022. This trial included patients with metastatic CRPC who had fewer minimal symptoms during treatment with enzalutamide, but were being treated with enzalutamide and did have disease progression. Almost 700 patients were included in this European trial, and patients were randomized 1-to-1 to receive continued enzalutamide and add docetaxel to the enzalutamide versus use a placebo pill, stop the enzalutamide, and add just docetaxel. So it was continued enzalutamide plus docetaxel versus docetaxel alone. And they were followed for a radiographic or unequivocal clinical progression endpoint. So a PFS endpoint that included clinical progression. I think this was a really interesting strategy as we think about how we take care of these patients, particularly those patients who have relatively few symptoms, because we think about the disease heterogeneity of men as they have further and further stages of prostate cancer in this mCRPC setting. We often think that the cells that may be most affected by treatment by an androgen receptor directed approach may be different than those cells that need to have chemotherapy added on. And use of different mechanisms of action may be really helpful as we try to control these different populations of cancer cells. Ultimately, when we looked at the progression-free survival endpoint for PRESIDE, we did see that there seemed to be a slightly longer progression-free survival achieved by patients who were in the combination of continued enzalutamide plus docetaxel versus docetaxel alone. The median PFS was 9.53 months versus 8.28 months. And this was a hazard ratio of 0.72 and had a p-value that was 0.027. So it was a positive or beneficial hazard ratio for the combination, and it was statistically significant. I think the question really is, it's the question that you asked. How significant is this? It's about a month and a half, 2 months of difference in terms of median PFS. This was really, as was actually stated in the meeting, about one scan length away, or even less than a scan length, one additional scan away. And so the question is really, was there just a difference in the way that we scanned these people, or was there some other thing that was kind of driving this? Even though it's a numerically significant difference, is this really a clinically significant difference? I think that ultimately my feeling on this is that if you have a patient that for some reason doesn't want to stop the enzalutamide, feels really attached, or you feel like there's a reason to believe that there's different populations, maybe there's actually stable disease in multiple lesions, but there's a single site or two that seem to have progression, it's safe because the side effect profile suggests it's safe to add the docetaxel on top of the enzalutamide, and you can use that treatment to try to suppress those clones or those cells that are continuing to grow. But it doesn't seem to give you a lot of bang for your buck to continue that enzalutamide. And I would say that's probably the case for most patients. So in most patients, if you're going to switch from enzalutamide or thinking about a patient who has progression of disease on enzalutamide and you're thinking about docetaxel, I would probably stop the enzalutamide and switch to the docetaxel. It's easier for the patient. There's no daily pills to take. There's no copay to pay. If you have a patient who, as I said, has this oligoprogressive metastatic CRPC, tolerating the enza really well, and you want to see if you can just get a couple clones under control with the docetaxel, it's safe to continue your enzalutamide and may be helpful for some proportion of patients who have that oligoprogressive type phenotype. I'd love to hear your thoughts on that and what you think about in terms of monitoring patients, especially if they're going to be on a combination.
Yeah, that's a really good question. And we know enzalutamide in general can be associated with increased fatigue and some CNS changes. It crosses the blood-brain barrier. So there can be insomnia, some cognitive impairment. There is an increased risk of falls and fractures. So I think having the patient on the enzalutamide for an extended period prior to even thinking about adding docetaxel, if that's what you want to do, it gives us a baseline and some stability in terms of side effects to help us determine once we do add the docetaxel, kind of like the offending agent, what would be causing what, so we know how to treat it. Docetaxel is a chemotherapy. It's given once every 3 weeks into a vein. The most common side effects are basically you watch for the blood counts, the hemoglobin, the platelets. In terms of tolerability, it's actually really well tolerated in our prostate cancer population. Low risk for nausea, though we do make sure patients have antiemetics at home. Peripheral neuropathies is important to monitor, both finger and toe. Patients can develop peripheral neuropathies. And in combination, if you think about it with the enzalutamide and increased risk of falls and fractures that have been reported, carefully monitoring for the peripheral neuropathies and trying to keep them to a minimum. Liver function tests need to be monitored as well as electrolytes. And then again, there is prednisone that would go with the docetaxel. So making sure patients are taking that. But in general, docetaxel is very well tolerated if patients are having symptoms that are related to their prostate cancer. With using docetaxel, we can actually see improvement in some of those symptoms because the docetaxel has a palliative kind of symptom improvement approach with controlling the prostate cancer, if that makes sense.
It definitely makes sense. Thank you for that.
Finally, let's look at the trial and the study design. Dr. Morgans, would you like to talk to us about that now?
Sure. So that trial is a phase 2 trial that was done by our colleagues in Australia and New Zealand, the ANZUP group. And this was a really interesting trial looking at patients who have metastatic castration-resistant prostate cancer who had previously been treated with docetaxel and who could be eligible for treatment with cabazitaxel as their next line treatment. As far as I understand, at least 80-90% of these patients also had treatment in the past with an AR targeted agent. So it essentially was a patient population that had really kind of exhausted their androgen receptor directed therapy options and was now looking at cabazitaxel as the next line of standard treatment. Patients were randomized 1-to-1 to receive lutetium PSMA 617 or cabazitaxel. And we'd previously seen progression-free survival data on this study that suggested that lutetium may have better progression-free survival than cabazitaxel in this setting, at least as far as that initial data that has been reported. Interestingly and importantly, at GU ASCO, there was a secondary analysis that was presented, which was looking at the PSMA and FDG PET scans that were done in the selection of patients for this trial to see if we could get a better understanding of those the utility of those different scans in this setting. Importantly, just to remind everyone, the patients eligible for this trial had to have a PSMA PET scan that was positive, but they also had to have an FDG PET scan that was only mildly positive or was negative. They couldn't have a patient who had multiple lesions, many lesions showing up as FDG enhancing, and only a few lesions that were PSMA PET enhancing. And the reason was lutetium is really targeting PSMA protein on prostate cancer cells. So if there's a lot of disease in the patient's system that is not going to be identified with a PSMA PET scan, that means that it's not expressing PSMA protein. And if it's not going to express the protein, there's a much lower likelihood that a treatment targeting that protein is actually going to be beneficial for the patients. So this was a hotly debated topic because the VISION phase 3 trial of lutetium PSMA 617 only included a PSMA PET scan in the selection and a CT scan, but no FDG PET scan. So in that trial, patients just had to have some degree of PSMA PET expression of their cancer lesions. And there were a couple other stipulations saying that they had to have lesions that were of reasonable size. And there was some stipulation around expression of the PSMA tracer in relation to the liver, but it was a little bit looser in terms of not needing that FDG PET scan to be done. So in this analysis that was presented at GU ASCO, the investigators were looking to see whether these two scans were actually going to be useful in helping to understand and specifically helping to predict which patients were going to respond to the lutetium treatment and which patients were maybe not going to respond. And they looked at both PSMA PET as a predictive biomarker of response to lutetium and FDG PET as a prognostic biomarker that might be useful in helping to guess which patients might do more poorly or do better with any treatment over time. What they found was that PSMA PET was highly predictive. And the cutoffs that they used were the SUV for PSMA, and SUV with a mean over 10 was predictive of a better response to lutetium versus less than 10, which was predictive of a poor response to lutetium. And the FDG PET, when those patients had a volume that was greater than or equal to 200, patients had a poorer prognosis than patients who had a lower FDG volume. So the way that this works, from my perspective, is that when you have a predictive biomarker, like the PSMA PET scan, you can use the PSMA PET to identify patients who you predict are going to actually, hopefully, fingers crossed, benefit from treatment with lutetium. If that PSMA SUV is very low, then you can predict that that patient probably will not have as robust of a response from treatment with lutetium. But the FDG PET, what you can say is if there's very high FDG expression, that patient is probably going to have a poor response to any therapy because that disease is more aggressive and the prognosis of that patient is poorer, regardless of what you do in terms of treatment. If that FDG volume is very low, so not a lot of FDG uptake, then that patient is probably going to have a better prognosis, a better outcome, regardless of what treatment you use. So it's really useful in kind of counseling patients about the disease aggressiveness rather than helping the patient choose a treatment that's going to be more effective or less effective.
So it sounds like we're still waiting to see how that may be incorporated into clinical practice.
Absolutely. And of course, we don't have lutetium yet in clinical practice. We are expecting that it may be approved at some point in the future. And I think this data speaks to the expectation that we do think that the label for lutetium, if it is approved, will probably be tied to the need to have PSMA PET positive cancer, and that those patients who are PSMA PET negative or their cancer is PSMA PET negative, they will probably not be indicated for treatment. And that goes right back to this predictive biomarker. If you're not going to have expression of the target, you would predict that that patient's not actually going to benefit from the treatment. So we anticipate that when lutetium is out there, it will probably have this tied to its label. Again, nobody really knows, but it probably will be there. And this is part of the reason why.
So just, kind of thinking ahead and hopefully that this will be approved. This is a radio labeled isotope, a little bit different than some of the things that we've had before. So in terms of the clinical trial and reported side effects and how best to monitor, what was mentioned at GU ASCO?
Sure. So I think one thing, and I'm going to ask your opinion on this later, is that I think that multidisciplinary care is really, really important in this context. So like I said, I'll ask you about that in just a second. But in terms of the side effects, what we've seen is that patients do have some mild fatigue. They can have some cytopenias as well, because this treatment does go into the bone marrow, especially if there seems to be a higher burden of metastatic disease in the bone marrow. And we also know that patients can have some uptake of lutetium in their salivary glands and sometimes in their lacrimal glands. And so patients can get dry mouth as a noticeable symptom and side effect. And that's something that we certainly encourage patients to think about using lemon drops or something that makes them salivate, because there's the theory, at least, that lots of salivation after you've been treated will help to clear some of that radioactive treatment out of your system. I would also mention that in terms of radioactivity, patients do have some precautions that they need to follow. Typically, what our team has suggested is that usually it's maybe 2 to 3 days where patients need to be a little distanced from others so that they don't have that close contact that could allow some radioactivity to affect their partners or their loved ones. And I think that that's going to be something that's important that we talk to patients about in terms of sleeping in separate places, using separate bathrooms, and having some degree of separation, maybe not spending a lot of time with the grandchildren in close contact, for example, in the days just immediately following that treatment. But I'd love to hear your thoughts on things like multidisciplinary management. How do you work together to give people treatments like this that really are maybe ordered by the medical oncologist or perhaps requested by the urologist, but certainly not given to patients in our clinics?
We were a part of the Vision trial, and so we had a really good close working relationship with nuclear medicine. And it took a lot of communication and just keeping everyone basically in the loop regarding patient labs. We had an order set, which was very helpful for us to order the medication. And then just the working back and forth and knowing our contacts really did make a big difference for basically seamless treatment for our patients.
I would 100% agree. Thank you for that.
Well, we're just about at the end of our time. So I want to thank you so much for listening today. We hope you enjoyed this. Please visit pce.is/ASCOGU to take the post-test and claim your credit for this activity. Again, thanks for joining us and have a great day.